लास्टमा भन्ने छ यहाँबाट गएर ट्विटर गएर टप गरेर
Okay, good afternoon, classes. Do you hear me?
Good afternoon, sir. Yes, sir.
Okay, so we'll start with today. We'll talk class on cerebrovascular accidents. Basically, I think it's written as a stroke also, so it's more or less similar. We'll talk about stroke or cerebrovascular accident. This is predominantly seen in the middle and late years of the life, and around there are many deaths because of this stroke, and in US and UK as well as in the whole world, and even in Asia or black people, they also have very high number of strokes, and because of the stroke, there are many deaths. And the incidence of stroke increases with the age, and basically these are usually present or seen in elderly patients or patient with comorbidities like hypertension, diabetes, or cardiac diseases. And however, most of the strokes are preventable, and it's very important to know why it occurs and how do we prevent it. If you look at the total stroke, then 80% of the stroke is because of ischemia and 20% of this because of hemorrhage. And if you look at in the hemorrhage part, the 40% of the patient with hypertensive intracranial hemorrhage die, but the rest survival, okay, 60% if they survive, then they can have a good recovery and complete recovery also. So hemorrhage in one set, it's like in acute conditions, it's quite has a high mortality, but if the patient recovers or can and survives that acute phase, then they have got a good recovery rate. So the stroke or cerebrovascular accident or CVA is broadly ischemia or hemorrhage. In ischemia, it's too little blood supply to a part of the brain, and hemorrhage is too much blood within the cranial cavity. And ischemia maybe because of thrombosis or embolism, or maybe because of systemic hypoperfusion. And hemorrhage it's either intracerebral hemorrhage or subarachnoid hemorrhage. In intracerebral hemorrhage, it can be because of hypertension or because of trauma. Patient can have intracranial hemorrhage. So it generally manifests as an abrupt onset of neurological deficit, and that should be a focal neurological deficit. This deficit may remain fixed or rapidly improve or may progressively worsen depending upon what is the pathophysiological mechanism of that stroke. This should be the abrupt onset should be non-convulsive, and it should be a focal neurological deficit. If these two words are very important when you define a stroke, non-convulsive and focal neurological deficit. So we generally define it as an abrupt onset of non-convulsive and focal neurological deficit that would define a stroke or CVA. Cerebral ischemia may be because of many conditions, like either it may be embolic or thromboembolic, and there will be a reduction of blood flow, and if it's lasts for a few seconds or more or a few minutes, then there will be a cerebral ischemia. And there are few terms like transient ischemic attack and stroke in progress, where in transient ischemic attack, when the blood flow is rapidly restored after brain tissue restored, and then brain tissue will recover fully, and there may not be any remnant of this stroke. So usually we define it as a signs, symptoms, usually which last less than 24 hours, are called TIAs or transient ischemic attack. Crescendo TIAs are just like an unstable angina. It's just equivalent to that. So increasing number of or increasing frequency of TIAs, then we call that one as a crescendo TIAs, and this is a bad prognostic sign also, because this will increase the chances of evolving into a complete stroke. So, so in a patient with a ischemic stroke, you may have history in past history of transient ischemic attack or crescendo TIAs. Stroke in progression means when the patient is suffering from a progressive neurological deficit over hours or days from the date of presentation of a stroke, and that deterioration in the neurological function should not be because of cerebral edema. If the patient doesn't have cerebral edema but the patient's neurological deficit is increasing, then we call that one as a stroke in progression. So another term is like when there is the neurological signs symptoms are more than 24 hours, then we call that one as stroke. And global hypoxia ischemic injury, which we call even as a hypoxic ischemic encephalopathy also, where you will have a generalized reduction in the blood flow rate due to systemic hypotension. So this is a little bit different from that of the stroke, where there will be a in a stroke, like suppose ischemic stroke, you will have an occlusion of a particular artery or arterioles. But here it's a generalized reduction in the blood flow rate due to systemic hypotension. Acute stroke presents with a focal deficit, and it may be like hemiplegia or paresis, with or without higher cerebral dysfunction, hemisensory loss, visual field defect, or brainstem deficit also. You know the difference between paresis and plegia. Paresis is the incomplete loss, or there is a weakness, but it's not a complete loss of motor power. But in a plegia, there's a complete loss of motor function. So here motor, if you grade it, then it will be a 0. Here it will be 1 to maybe 4 plus or something like that. So there's a difference between plegia and paresis. Usually, cerebral hemorrhage produces neurological symptoms by 2 mechanisms. One is the hemorrhage will produce the mass effect, and which will press upon the neuronal structures, so that there will be a dysfunction. And second one is the toxic effect of the blood itself can cause the death of a neural cells, and so there will be a neural dysfunction also. Whenever we examine or we manage a patient with a stroke, then first thing that we always try to do is whether it's a ischemic stroke or a hemorrhagic stroke, and we should have 2 goals. One is to prevent or reverse acute brain injury, and to prevent the future neurological injury. So our treatment goal should be to prevent or reverse acute brain injury and to prevent further injury. There are few causes of, like, I shouldn't say few, but there are causes of the stroke, which may be because of thrombosis or embolic, cardioembolic, or paradoxical embolic, or maybe because of hypercoagulable state, fibromuscular dysplasia, vasculitis, then maybe a subarachnoid hemorrhage causing vasospasm, drugs, Moa disease, or eclampsia. These are the causes of the stroke, and Generally, we get a thrombotic stroke, embolic, maybe because of from the heart, like in patient with atrial fibrillation presenting with ischemic stroke, or maybe in cases of mitral stenosis, which usually due to is because of atrial fibrillation as well. So another important causes are connective tissue disorders, the hypercoagulable disorders like protein C deficiency, protein S deficiencies, in nephrotic syndrome, or use of oral contraceptives in young females. And SLE is very common, it can present with stroke in young females. And there are many vasculitic syndromes like Wegener's, Takayasu's, giant cell arteritis, even CNS vasculitis can cause some of the meningitis like syphilis, tuberculosis, fungal, bacterial tuberculosis. The meningitis can cause stroke. So as I told you earlier also, there may be atherothromboembolic stroke or atherothrombotic stroke. Here you'll have two things, like there may be a intracranial vessel producing local thrombosis, or distal thrombus which has embolized from another place. So you can have both here. In atherothrombotic stroke, there will be a, this is usually seen in large vessels with large thrombus, and it's usually because of atherosclerosis. In lacunar syndrome, there will be a thrombotic occlusion of smaller intracranial vessels, and this is also very frequent causes of stroke, and usually it's because of lipohydrosis. Whenever we look at the patient with the stroke, our main aim would be that where is the occlusion, okay, and what is the, whether it's ischemic or hemorrhagic, which artery is involved, where is the location, and what is the etiology. We should be looking for these, and the extent of the neurological ischemia is determined by location of the occlusion, whether there are collateral circulation or not, and even the blood pressure and body temperature. We'll talk about blood pressure and body temperature in the treatment part also. In the thrombotic strokes are usually gradual in onset and may stutter. And these are common in a patient to experience several episodes of TIAs, and patient may give history of TIAs in these patients. Embolic is a sudden onset, and they would be maximum at the onset. So if a patient has got atrial fibrillation, and if a clot skips from left atrium into the brain, then there will be a sudden onset of neurological dysfunction, and the onset will and the neurological deficit will be maximum at the onset. There are few risk factors like older age, male sex, race. Blacks are more commonly involved with ischemic stroke. If there are family history of thrombotic stroke, diabetes, hypertension, heart failure, atrial fibrillation, endocarditis, smoking, excessive alcohol, increased cholesterol levels, polycythemia, in females particularly oral contraceptive pills, and the risk factors for ischemic stroke. Hemorrhagic stroke can be intraparenchymal, sometimes intraventricular, this is subarachnoid hemorrhage, where you'll have a hemorrhage in the intraventricle also, and maybe because of trauma, and mostly putamen, thalamus, cerebellum, and pons are involved in hemorrhagic stroke. Putamen is very, very important place for hemorrhagic, hypertensive hemorrhagic stroke. Maybe usually increase in advances, heavy alcohol and cocaine use, and this may be large enough. Okay, hemorrhagic stroke, hematoma, the presence of hematoma may be large enough to compress the adjacent tissues and sometimes cause herniation and death also. They may spill into the ventricles, and this will increase the morbidity and mortality and may produce obstructive hydrocephalus. The one thing is very particularly we use um, this point to differentiate whether patient has got hemorrhage or ischemic stroke by history. Usually, the ischemic strokes are usually occur at the early morning when the patient is sleeping, but hemorrhagic strokes are almost always while the patient is awake. There will be an apparent onset, but typically worsens over an hour or so. And this is often associated with decreased level of consciousness and headache with vomiting. If the patient survives, then there will be a liquefaction of clot and will be absorbed. So there will be only a small residual cleft, and this usually takes around 1 to 6 months. So when I told you about the hemorrhagic stroke in first slide, in acute phase, the mortality morbidity is very high, so the 40% of the hemorrhagic stroke can die. But the remaining 60%, because of this liquefaction of clot and absorption of clot, there will be an improvement in the neurological deficit, and there will be only a small residual neurological deficit present in the patients. So they recover well, very well. Before going through the stroke signs and symptoms, we should have a very gross idea about the blood supply. Usually it is supplied by anterior cerebral, middle cerebral, and posterior cerebral. In the anterior cerebral, usually in the frontal lobe, and the part of the internal capsule. Um, but the majority of the parietal lobe is with the middle cerebral artery, and the internal capsule is also supplied by the deep branches or the anterior choroidal artery of branch of the middle cerebral artery. The thalamus, red nucleus, and these and the part of the brainstem, these are also are supplied by usually by the posterior cerebral artery. Why this is important is that if you have a problem, if the part of the anterior cerebral artery is occluded, then the sign symptoms will be compatible with frontal lobe. If the middle cerebral artery then is occluded, then you will have a sign symptoms that would be from the internal capsule or from the okay. Mm, then there will be a contralateral hemiplegia or hemianesthesia. there will be homonymous hemianopia. Gaze preference would be in the ipsilateral side. That means on the, if the left is involved, then there will be a, the patient's eyes would be deviated towards the left. If there is a involvement of dominant hemisphere, then the patient will have aphasia as well. So as you know that you will have a, can you mute? Someone has got there's a disturbance because and if the patient has got involvement of left hemisphere, left hemisphere or left middle cerebral artery, then it is in a patient with a right-handed or left-handed patient, the left hemisphere is a dominant hemisphere for them. So if the patient has got involvement of left hemisphere, then the language area, that is Broca's and Wernicke's areas, are present in the dominant hemisphere. So if there is a involvement of entire middle cerebral artery, then you'll have a global aphasia. That is why you'll have a global aphasia. Anterior can supply some part of the internal capsule, so they may have a bilateral pyramidal signs with paraparesis, and the another one is that they will have a urinary incontinence with behavioral changes because because of the involvement of frontal lobe. In the posterior artery, patient may have vertigo, diplopia, hoarseness, dysarthria, dysphagia, or if the patient has got medial medullary syndrome, then we can have hemiparesis, contralateral loss of joint position, and tongue weaknesses as well. Usually, if the patient has got involvement of cerebellum, then patient may have sudden respiratory arrest because of the compression of the respiratory center because of the hematoma. There may be disturbance in gait. Patient may complain of giddiness, nausea, and vomiting. And if the patient has got like a very large hematoma within the brain stem, then patient may die because of the pressure over the respiratory center and pressure over the cardiovascular centers. This is like a time course which is quite important to differentiate whether it's a hemorrhage or infarction or thrombotic. In thrombosis, there may be a stuttering time course, like a patient may be having deterioration in the neurological function, patient improves, then deteriorates. It would be something like this. So this is a recurrent TIA, maybe a TIA or maybe a stroke itself, but can have a stuttering time course like this. But if they're in a hemorrhage, patient may show the unusual behaviors initially, then there may be a weakness which gradually increases, and the conscious level also gradually deteriorates. In the lacuna infarct, patient may not have a complete loss of weakness or the motor function, and patient may have improves in maybe a week or days of maybe in 15 days like that. But if the patient has got, we don't have a embolic time course for embolism, the patient's weakness will be sudden in onset and maximum at the onset. So the weakness will be the graph for the weakness will be here, and then it may remain like this, or it may gradually improve somewhat. As I told you that there may be uh, there are few things with the neurological examination also we can differentiate whether this is because of intracranial hemorrhage or because of edema or because of the is it a ischemic stroke in if there is a weakness the face, arm, leg on the same side, which is accompanied by sensory, visual, or cognitive abnormalities. That is, this is a pure motor stroke. Then this should be more favoring thrombotic stroke. If the patient has got large focal neurological deficit, which is very abrupt, progresses quickly and maximum at the onset, then it's an embolism. But it's when it's not a maximum at the embolism at the onset, then it may be an intracranial hemorrhage. If you have a vertigo, diplopia, deafness, cross symptom, that means patient has got weakness of the left seven cranial nerve and weakness of the right hand or right leg, then it's a we call that one as a cross symptoms. That may suggest that patient may have posterior circulation involving the brainstem. If the patient has got sudden onset of severe headache, vomiting, and may have an impaired consciousness, but may not have a focal neurological signs, then that may be a case of subarachnoid hemorrhage. So with the history also, the history may also suggest that whether this is a intracranial hemorrhage or the ischemic stroke or subarachnoid hemorrhage. Another thing that is also used sometimes is called Sri-Raj scoring, where you have got many parameters in the score, and with the help of that score also you may be able to say whether it's a ischemic stroke or whether it's a hemorrhagic stroke. As I told you earlier, the site of obstruction will have a infarction in the different areas, producing different clinical manifestations. In the investigation, we generally send it for complete blood count, where we may be able to find polycythemia or thrombocytosis, thrombocytopenia, or maybe evidence of concurrent illnesses like meningitis. In the chemistry panel, especially we look at for the blood sugar level and electrolytes, because these two are very common differential for a patient who is unconscious and which can be corrected rapidly also. And this may also provide evidence of concurrent illnesses like diabetes or renal insufficiency. We may have to do cognition studies or cardiobiomarkers. Usually D-dimer, we don't generally do this test, but in some centers they do D-dimer test, which is highest in cardioembolic stroke and cerebrovascular thrombosis. Toxicological screenings are done in very limited cases where you suspect misuse of drugs like cocaine or amphetamine, then toxicological screens can be done. Imaging CT scan is very, very important, and it's mandatory. And this can also differentiate whether it's ischemic or the hemorrhagic. And and it will also guide the plan management. If the patient has got acute ischemic stroke, then we can go for thrombolytic therapy. If the hemorrhagic stroke, then we have completely different diagnostic and therapeutic pathway. CT scan can also rule out whether there are hematomas, neoplasms, or abscesses, which may present as a cerebrovascular accidents. This also can prognosticate if the patient have, with the volume of the blood in the supratentorial area, if it is less than 30, then it has got a good prognosis. But if it is more than 60 mils, then they have got a poor prognosis. In posterior fossa, if the hematoma is of less than 1 centimeter size, then the patient will be alert, and there won't be any focal neurological deficit, and surgery may not be necessary. If it is more than 3 centimeter, hematoma is more than 3 centimeter, then it definitely requires the surgery. There are, even MRIs are nowadays done, and this may be quite useful in acute ischemic stroke, because in CT scan, sometimes what happens is, if you do a CT scan of a patient within 6 hours of 6 hours of incident, then CT scan may be normal, but MRI can pick up those lesions, and thus it will help the patient to get. But it's costly, and it's not really available in all the centers. So MRIs are usually done as a second choice of investigation. We go for electrocardiogram, and sometimes angiography is necessary, especially in patient who may have aneurysm as a etiology for the hemorrhage, or for patient with fibromuscular dysplasia, vasculitis, then the angiography is important. And with the help of this angiography, they may even go for surgery in aneurysm. So the initial assessment, you go for ABC airway. Then you looked at the serum glucose level, go do a CT scan. If it is a hemorrhage, then we go for medical or surgical management. If it is a tumor, then or other CNS processes, then treat accordingly. You try to maintain the, if you have a ischemic stroke, then you should consider for hemolysis, starting of aspirin, maintain blood pressure, and hydrate the patient, and they admit the patient to appropriate level. Nowadays, we have got a stroke unit in most of the hospitals, and they manage the patient in stroke unit like that of cardiac care unit for cardiology patients. We try to establish the cause of stroke and look at the risk factors, and then plan for the secondary prophylaxis. Then we need a physiotherapy, whether it may be a physical, occupational, or speech physiotherapy, and to help them. And we established the nutrition, and this was later on with planning for risk factor reduction, If the patient is hypertensive, then we go for antihypertensive treatment, antithrombotic medication prophylaxis if necessary. Then especially antithrombotic medications are usually given in those patients who have got atrial fibrillation as a etiology of ischemic stroke, like warfarin. We give warfarin. There may be complications like chest infection, dyselectrolytemia, hypoxemia, hyperglycemia, DVT, frozen shoulder, pressure sores, UTI, constipation, which we have to deal with. This is the hemorrhagic stroke, and this is a ischemic stroke that is evident in CT scan. This is a ischemic stroke in the cerebellum. This is a hemorrhagic stroke in cerebellum, and this is SAH. Sorry, this is subarachnoid hemorrhage. And for the treatment, for the acute ischemic stroke, we give a medical support, IV thrombolysis, or sometimes endovascular revascularization, antithrombotic treatment, neuroprotection, and prevention, primary or secondary. For the blood pressure, it should be reduced if the patient has got blood pressure of more than 220 by 120. More than 185 by 110 if thrombolytic therapy is anticipated. Fever is very detrimental and should be treated with antipyretics and surface cooling. Surface serum glucose monitoring, and it should be kept under 180 but should avoid hypoglycemia. Patient may have cerebral edema, so we may have to restrict water or give IV mannitol. We can put the patient in propped up position. Even with the help of the ventilators also, we can decrease cerebral edema. We have to prevent the complications of a bedridden patient like infection, like hypostatic pneumonia, urinary tract infection, or skin, DVT, pulmonary embolism, even bed sores. For the DVT, you can give heparin, low dose heparin, if the patient is not having hemorrhagic stroke. But in hemorrhagic stroke, DVT may be contraindicated, so you may have to give the physical measures like the stockings. You can give stockings to prevent DVT. And lastly, we look at the treatment of the causes. Like if the patient has a atrial fibrillation, then we try to control the rate. And if the patient has got increased chances of having the clots in the LA, then we give antithrombotics or anticoagulants, like in the anticoagulants like warfarin or any newer anticoagulant drugs. If the cause is because of connective tissue disorders, then we treat connective tissue disorders with steroids. If the patient is because of thrombocytopenia, then we may have to transfuse platelets. If the patient is taking warfarin and because of the warfarin patient has got hematoma causing a stroke, then we may have to give vitamin K, stop the anticoagulant drug, and we treat infection like meningitis and stop drugs like amphetamine, cocaine, or other drugs that can cause stroke. For the thrombolysis, usually rtPAs are usually given, which is a recombinant tissue plasminogen activator, and usually it should be given within 4.5 hours. And for the contraindication, if the blood pressure is more than 185 by 110, if the patient has got bleeding diathesis or recently had an injury, major surgery in 14 days, gastro bleeding in 21 days, or recent myocardial infarction, then we should not give these rtPAs. So, and usually intravenous thrombolysis are usually done for the thrombosis of the small vessels. But if the patient has got thrombosis in the large vessels, then the thrombolysis may not be very helpful, and at that time a patient may have to go for endovascular surgery to remove the thrombus, which is thrombectomy. So this is the last slide, and if you have any questions, then I may be able to answer those. Okay, then if you don't have any questions, do you have any questions? Okay then.